Hi there, it's Dr. Ryan, and today I want to talk a little bit about a topic that has been brought up pretty frequently in my clinic, and that is how to preserve fertility while on testosterone replacement therapy. And to kind of organize my thoughts, I prepared a short presentation on why I utilize my treatment regimen and some background as to why HCG is important for this. So let's go ahead and start that. Okay. So, first things first, let's talk a little bit about the hypothalamus, or rather, this is an abridged view of reproductive endocrine physiology. And it starts really with the hypothalamus. The hypothalamus is a portion of your brain, which is very important in the endocrine system. It secretes several different hormones. The one hormone they're most interested in is gonadotropin releasing hormone. This therein acts on the pituitary, another important component of the endocrine system, which is also found in your brain. And a certain section of the pituitary, the anterior pituitary, releases luteinizing hormone and follicle stimulating hormone. These are important hormones in the stimulation of the gonads, both in male and females. In males, it produces testosterone and sperm production, spermatogenesis. In females, it produces estradiol and progesterone. LH seems to be more important in terms of testosterone production, although there is some, and intratesticular testosterone production, whereas FSH seems to be more important with spermatogenesis, although there may be an overlap between the two. Another thing to note is as your testosterone levels rise, there is a negative feedback loop on both secretion of gonadotropin releasing hormone from the hypothalamus and LH and FSH from the anterior pituitary. So as you inject testosterone, which is exogenous testosterone outside of the body, your natural production of testosterone drops. And that's why in many cases, some patients will see a slight decrease in size of their testicles and will likely see decrease in sperm production when they start on a TRT regimen. But is there a way to perhaps prevent this or decrease that process from occurring as much? And in fact, there is. Well, we're going to talk a little bit about HCG, but let's just introduce a little bit about what it primarily does in the body outside of being utilized in TRT. HCG is a hormone, human chorionic gonadotropin, that is released by the trophoblast layer of the placenta in the developing embryo. And what it does is it binds, or it is released and then attaches to the corpus luteum, which is the remnant of a follicle. So of course, during ovulation, a follicle is grown in the ovary, and then that oocyte is released into the fallopian tube. And then if it undergoes fertilization, it becomes an embryo, which then implants in the uterine wall, right? Now, the remnant of this follicle is known as the corpus luteum. The corpus luteum has effects on the uterus, and that HCG will act on the corpus luteum, and then it will then produce progesterone, which then maintains the endometrium, thickens the cervix, as well as increases arterial blood flow to the growing and developing embryo, allowing it to get adequate nutrition. Now, why would you think that we would use a hormone that's involved in maintenance of a developing embryo in the mother's uterus for TRT? And that's a valid question. But interestingly, HCG and LH are very similar in their structure. The alpha subunit, or this portion of the protein, is almost exactly the same, whereas the beta subunit is a little bit different. The beta subunit has these extra carboxy terminuses. These I believe are serine amino acids, and they have 4 extra ones versus LH, which does not. And what that does is they both have very similar functions in the body. However, owing to these extra 4 amino acids, HCG has a much longer half-life than LH. LH only has a half-life of about 20 minutes, whereas HCG has a half-life of close to 24 hours, which makes it a much more desirable drug when you're trying to stimulate your testes to produce intratesticular testosterone, or facilitates spermatogenesis. Now, in the past, there have been a couple of algorithms produced to on how to maintain fertility in the setting of testosterone replacement therapy. So the first thing, of course, to do is to establish a baseline semen analysis. So before you start, you obviously want to check to make sure your sperm production is appropriate, your semen production is appropriate, right? Because if there are any issues prior to TRT won't necessarily fix them, and you'll know that, hey, there's I have some issues with perhaps ejaculation or sperm production prior. And then, according to this algorithm from the Asian Journal of Andrology, um, there are different treatment regimens for different temporal periods as to when you would like to desire a pregnancy. So if it's greater than 12 months, they suggest actually coming off testosterone replacement therapy every 6 months with a forward cycle of HCG, which I don't, this is a little controversial. I don't necessarily think that's necessary, but some clinics do that. And then when a pregnancy is desired, continue testosterone replacement therapy, but add 500 IU of HCG and plus or minus Clomid. And then less than 6 months, completely stop TRT, start 3000 IU of HCG and add in Clomid. So again, and then if that doesn't work, add in FSH or minotropins every other day. Now, this definitely is a protocol that can work, but what I found interestingly is a much simpler protocol has allowed most of my patients to maintain fertility while they're on TRT. That doesn't require them to be on both Clomid and HCG, and certainly not the levels of HCG that you need. Now, remember, HCG has side effects. At lower doses, you don't seem to see them, but at higher doses, it tends to cause quite a bit of water retention owing to its increased estrogen production. And there is some issue perhaps with arterial disease as well at higher doses, arterial thrombus. And so it's not a wholly, well, no drug is wholly safe, but it's not a drug that's completely lacking in side effects. And then clomiphene, of course, uh, Clomid is a drug that binds to, it's a SERM, a selective estrogen receptor modulator, which acts primarily on the hypothalamus. So back over here. And what it does is it basically promotes gonadotropin releasing hormone. And, it seems like that's a good idea. But the problem is with neither HCG or Clomid, do you get very exact titration of testosterone, or at least to the same degree that you can with testosterone replacement therapy. So both of them, in my mind, are inferior alternatives to testosterone replacement therapy for treating somebody with low testosterone. And if you can avoid them, if at all possible, and still maintain spermatogenesis, you can avoid some of the side effects. As I mentioned with HCG, it's owing primarily to the estradiol with Clomid. Other things such as visual acuity issues secondary to the overstimulation of the pituitary can cause it to grow a little bit and potentially compress the optic nerve. And then it has negative effects on patients' lipid panels over time, decreasing HDL, increasing LDL. And so ideally, if you can get away with smaller amounts of HCG and avoid Clomid, that would be a good idea. But is that really possible? And has that been demonstrated in literature? Well, it has. So here's an article from the Journal of Clinical Endocrinology, and it was published in 2005. And it basically looked at how a group of individuals were treated with low-dose HCG and how it maintained intratesticular testosterone in patients who are on TRT, right? And so some of you might be thinking, well, we're talking about sperm production, not intratesticular testosterone. Well, the two are highly correlated. And the higher your intratesticular testosterone or more closely related it is to baseline, the higher the likelihood that you will maintain sperm production. So in this particular study, 29 men with normal reproductive physiology were either randomized to receive a once weekly shot of testosterone enanthate, and that's 200 milligrams, with either a saline placebo or 125, 250, or 500 IU of HCG every other day for 3 weeks. And then they went ahead and had their intratesticular testosterone levels assessed by percutaneous fine needle aspiration. Now, what was interesting is LH and FSH were profoundly suppressed. Well, this was a given. So, given the fact that the patients that were receiving testosterone and as I mentioned earlier, the people that were on saline had profound suppression of LH and FSH, and thus had profound suppression of intratesticular testosterone. It was suppressed by almost 94%. So, in other words, as we might expect, their intratesticular testosterone levels and thus their spermatogenesis was significantly depressed, right? However, this intratesticular testosterone seemed to increase linearly with increased ACG dose. So in the 125 IU HCG group, it was only 7%, it was 25% less than baseline. In the 250 IU HCG group, it was 7% less than baseline. And in the 500 IU HCG group, it was 26% greater than baseline. So greater than baseline if you were on HCG, and it kind of leads one to think perhaps if you're on HCG 500 IU every other day, you're likely to have a greater than higher intratesticular testosterone level, and thus not really impact your spermatogenesis. So the next question might be, well, looking at intratesticular testosterone is all well and good, but was there a study that looked at actual sperm production and established whether or not 500 IU every other day really worked? Well, there actually was. So in the Journal of Urology, and this article was published in February 2013, it showed that concomitant intramuscular HCG preserves spermatogenesis in men undergoing testosterone replacement therapy. So let's take a look at this one. So they looked at 26 men with a mean age of 36 years, and the follow-up was 6.2 months. And they were either treated with testosterone or transdermal gel. And everybody had 500 IU of beta HCG every other day. Okay. And so prior treatment, their total testosterone levels were 207, and after it was 1,000 nanograms per deciliter, which is appropriate. And these are mean serum hormone levels. The mean free testosterone is 80 versus 20.4, very good. And estradiol was 2.2 versus 3.7. Okay. And then their pre-treatment semen parameters were a volume of 2.9, density of 35.2 million per milliliter. And this is important because you're considered oligospermic. So having a low sperm count, if you're less than 15 million per milliliter, 15 million sperm cells per milliliter, and then you're considered azoospermic if you don't have any sperm per milliliter, right? 0 sperm per milliliter. And so again, pre-treatment, this is why it is important perhaps to get this tested prior to TRT, just so you have a baseline, right? These individuals are normal, and there were no differences in semen parameters observed during greater than 1 year of follow-up. Very interesting, right? So no impact on semen parameters were observed as a function of testosterone formulation or just the therapy. And to make things even better, no patient became oligo or azoospermic during concomitant testosterone replacement in HCG. So that's really cool. So in other words, when they tested all of these individuals, not a single one became azo or oligospermic despite being on testosterone replacement therapy. And as has been also indicated by my clinic, 9 of the 26 men contributed to pregnancy with a partner during follow-up of the people that wish to have pregnancy, which is pretty good, right? And so it seems likely that adding HCG at 500 IU every other day is likely to preserve fertility in patients on TRT. So hopefully this kind of gives you guys a good idea of my thoughts on HCG and TRT. I will say this doesn't work for everyone. There always are exceptions, and there are a few individuals every so often that do require higher doses of HCG and/or require gonadotropin, FSH. But in those particular cases, after adding the HCG and if they needed gonadotropins, practically everyone was able to get their sperm count out. Now, again, getting your partner pregnant also requires her physiology to be appropriate. So there were some cases where individuals in the clinic weren't able to get their partner pregnant, but it was owing to their partner, unfortunately. And the other point to remember is in my clinic, I try not to use testosterone levels as high as what some of these individuals in the studies were utilizing. So they were using testosterone levels that were closer to 200 a week. I try to keep my patients on anywhere from 80 to 150 in smaller doses that are more physiologic. So they're split to either thrice weekly or every other day dosing. And I feel that seems to dysregulate or seems to decrease dysregulation of the um, reproductive endocrinology within these patients as well, which allows them to perhaps not have as much suppression of spermatogenesis and therefore intratesticular testosterone. And when you add the 500 IU of HCG, it oftentimes leads to a good result. Okay, so hopefully this has been helpful to anyone who's been concerned about fertility while on TRT. And I'll catch you guys in the next video.